cavity cancer treated with surgery alone, a retrospective review. Next, please. The primary modality of most early oral cancer, stage 1 and 2, is single modality, mainly surgery. Radiotherapy is usually not indicated in early oral cavity cancers, but still not all early oral cancer treated with surgery alone behave in a similar fashion. There are several pathological factors like tumor grade, worst pattern of invasion, lymphovascular invasion, perineural invasion, independently and or in combination, which may influence recurrence. And recurrence, however, is associated with worse prognosis despite the salvage treatment. The aim of our study was to analyze the oncological outcomes in patients of early oral cavity cancer treated with surgery alone. The primary objective was to analyze 5-year overall survival and recurrence-free survival in such patients, while secondary objective was to assess the patterns of failure and to assess the high-risk pathological factors affecting survival or recurrence in early oral cavity cancers treated with surgery alone. It was a retrospective study conducted from January 2012 to December 2017. We had total 113 patients with median follow-up of 60 months. The inclusion criteria was patients who were previously untreated, pathologically proven squamous cell carcinoma of oral cavity, pathologically stage P, T1, T2, N0, M0, who underwent surgery were included in the study. Patients who received any neoadjuvant treatment, post-operative adjuvant treatment, and with history of previous head and neck cancers were excluded from the study. Elective neck dissection was done in all cases except 6. The overall survival and recurrence-free survival of the entire subject population was analyzed. Overall survival was the time between the date of surgery to the date of death, and locoregional recurrence-free survival was the time between the date of surgery to date of recurrence. We further investigated what were the patterns of failure, the prognostic factors which affected either survival or recurrence in our study. So these were the variables we included from each individual: age, sex, occupation, risk factors, family history, performance status, tumor location, surgical procedure, including the neck dissection detail along with the type of reconstruction, PTNM, we included PT1, T2, N0, M0, cases only, grade of differentiation, tumor size, depth of invasion, perineural invasion, lymphovascular invasion, margins, the closest margin was taken into account, date of recurrence, pattern of failure, and last date of follow-up or death, whichever available, whichever was earlier. The retrospective study was approved by the institution ethics committee, and the informed consent was waived as it was a retrospective nature. Data management and storage was done by the principal and the co-investigators only. Others did not have access to the database, and we did with all the ethical, taking all the ethical issues into consideration. Statistical analysis was performed using SPSS software version 21. Overall and recurrence-free survival was calculated using the Kaplan-Meier method. Pattern of survival, prognostic factors affecting survival or recurrence was calculated by univariate and multivariate analysis using the Cox proportional hazard model. A p-value less than 0.05 was considered statistically significant. Next, please. In our study, the median age of the study population was 54.5 years. 73.5% of the patients were males, while 26.5% were females. 95.6% had history of tobacco consumption, mostly smokeless form. As in our part of the country, which is the northeast part of the country, there is rampant use of the smokeless tobacco in form of the betel quid mainly. So maximum of our patients had history of smokeless tobacco consumption. 29 patients had family history of cancer. 25 patients were stage 1 and 88 patients were stage 2. The most common site in our study was the buccal mucosa, followed by tongue, followed by the lower gingival buccal sulcus. There were 31 recurrences and 24 deaths. Local recurrence was, however, the most common pattern of the recurrence. Using the Kaplan-Meier method, we found out that the 3-year and 5-year overall survival was 92% and 71.8%, while the 3-year and 5-year recurrence-free survival was 77.9% and 69.4% respectively. This is the overall graph showing the overall survival of our population, study population. This is a graph showing the recurrence-free survival of the study population. So as we can see that the most of the patients had primary recurrence. So that was the primary site recurrence. So that was the most common pattern of recurrence in our study, while very few had regional and distant metastasis. When we looked into account the various pathological factors, we found out that the perineural invasion and grade of differentiation affected the recurrence-free survival, and this was statistically significant when it was in consideration to the recurrence. So these two factors did affect the recurrence statistically significantly, but none of the pathological factors had significant association with the overall survival. Perineural invasion, however, showed the closest association with the overall survival. This is a tabulated form of the data, which shows that the 5-year overall survival was 71.8% in our study. And we can see that none of the factors like the age, the grade of differentiation, the stage, the lymphovascular invasion, perineural invasion, or margins, none of them was statistically significant with respect to the overall survival. So none of the factors affected the overall survival. However, we can say that perineural invasion did have a closest association. Next, please. Yeah, and the recurrence, no, just the previous slide. The previous slide, please. Yeah. So the recurrence-free survival, 5-year was 69.4%. And we can see that the grade of differentiation and perineural invasion had statistically significant association with the recurrence-free survival. So poorly differentiated histology and the presence of perineural invasion affected the recurrence in our study. Am I audible? Okay, next slide, please. So we can see that the presence of perineural invasion drastically decreased the recurrence-free survival in our study. We can see there is a large gap between the presence of patients with presence of PNI when compared to the absence of PNI. Now we can, this is the graph showing the perineural invasion, how it affected the overall survival. So presence of PNI did affect the overall survival, but this was not very statistically significant. So there have been multiple studies regarding these high-risk pathological factors, the outcomes in early oral cavity cancers in the past also. Lurie et al. Used the National Cancer Database data to study survival in 6,830 patients with exclusively early stage oral cavity cancers. Overall survival at 5 years was 69.7% in their study, which was in close association with ours. According to the SEER database, which enrolled 6,791 patients with stage 1 and 2 squamous cell cancer oral cavity, the reported 5-year disease-specific survival of stage 1 and 2 cancers was 83.5%. But they had mostly tongue carcinomas. This study was conducted in 2018 by Lanching Zhu et al. They compared the options of treating early oral cavity cancers. They divided the study population into 3 groups. It was a retrospective study. The groups were preoperative radiotherapy. The second group was the only surgery, and the third group was the post-operative radiotherapy. So they concluded that, sorry, please go to the next previous slide. They concluded that compared with the surgical therapy alone, radiotherapy, when combined either preoperatively or postoperatively, did not improve the 5-year survival or did not reduce the recurrence. So they concluded that surgical therapy alone was a preferred option for treating early oral tongue carcinomas. Next. This was the study conducted by Ian Ganley from the MSKCC group, which showed that in early tongue cancer, they found that 5-year disease-specific survival was 86%, overall survival was 79%, and recurrence-free survival was 70% in their study. And they also found out that they included patients with clinical T1, T2, N0. So they found out that the presence of occult metastasis was the main independent predictor of overall survival, disease-specific survival, and recurrence-free survival. Also, a positive surgical margin was the independent predictor for local recurrence-free survival, and depth of invasion was main predictor for neck recurrence-free survival in their study. Next, please. Shim et al. Reported 5-year overall survival and disease-free survival in T1, T2 tongue carcinoma of 80.8% and 80.2%, which was higher than our data. In the same study, they found out that there are various histopathological factors that may influence recurrence. So according to them, higher tumor grade and depth of invasion more than 5 mm was significant prognostic predictors affecting both overall survival and disease-free survival. Next. This is the paper by the Shim et al. Published in the Radiation Oncology group, which showed that higher tumor grade and depth of invasion more than 0.5 centimeter affected the prognosis of the patient, and post-operative radiotherapy may be considered in such cases. A study conducted by the Taiwan group showed that poorly differentiated histology and depth of invasion more than 5 mm and perineural invasion showed adverse impacts on both overall survival and recurrence-free survival. Next, please. This was a systematic review of 13 retrospective studies conducted by Andre Sember et al. In 2015 regarding the presence of the perineural invasion in early oral cavity cancers and whether adjuvant radiotherapy should be considered or not. So they found out that there was evidence lacking to recommend adjuvant RT in all patients of head and neck carcinomas with PNI. But they also suggested that large nerve perineural invasion or multifocal perineural invasion may predict worse outcome and may be appropriate indication for adjuvant therapy in early oral cavity cancers. This was the review conducted by the Amrita group from the India, where they found out that presence of more than one adverse pathological factor in early oral cavity cancer could be benefited from post-op adjuvant radiotherapy. So the pros of our study was that the study had a long follow-up period of 60 months. So a 5-year survival we could ascertain by our study. And it included solely those patients with SCC P1, T2, N0. Since, as we know, the presence of N plus NEC does affect the prognosis, so to avoid the bias, we included only those patients who were node negative. Also, single modality treatment was taken into consideration, and the strict inclusion and exclusion criteria allowed to evaluate the effect of adverse prognostic variables on early oral oncological outcomes. The cons of the study that it was retrospective in nature, and due to the lack of the availability of the complete data, the sample size was not very enormous. And we did not include the worst pattern of invasion or tumor budding as a factor for analysis because it was not reported in all patients because of the time frame of the study. However, it is an important variable to be included nowadays. It has been updated in the AJCC 8th edition, so that was missed in our study. To conclude, I can say that more than 1/4 of the early oral cavity cancer treated with surgery alone developed recurrence in our study, and a poorly differentiated histology and perineural invasion were the high-risk factors influencing recurrence. So we can say that post-operative adjuvant therapy may be considered in presence of these high-risk factors. However, we still need randomized control data to solve this query further. These are my references for the study. Thank you.